Hello and welcome to webinar series. So Shanti here this side, and today's topic for discussion is all about orthopedic specific pre and post-operative care. For this discussion, I like to welcome our expertise, none other the great surgeon, Dr. Sunil Dachpalli Garu, who is our clinical director, senior consultant, orthopedic, robotic joint replacement, shoulder, sports, and trauma surgeon from Somajigora Unit, Yashoda Hospitals. I welcome you, sir, and indeed it is our privilege to learn from you today. I welcome you, sir.
Thank you. Can you hear me?
Yes, you're audible,
Yes,
sir.
sir.
And also, I like to extend my welcome for all our speaker in the panels, Miss Aparna, Miss Rachel, and Miss Monica, as
Thank you.
this session is going to be very time bound. And yes, over to you. Let us see what we have in the rest of the session. Aparna, take over.
Good afternoon, everyone. Am I
Hi.
audible?
Yes,
Yes.
you are.
Yes.
Good afternoon, sir. Thank you for taking the time to share your expertise with us today. I am Aparna, working as a nurse manager in Surgical HQ, Yashoda Hospital, High-Tech City. I truly appreciate these opportunities to learn from your vast experience in orthopedic and robotic assisted surgeries. Before proceeding
Yeah.
I would like to ask you one question, sir.
Yeah.
Doctor, beyond the surgery itself, why is orthopedic specific nursing care vital for the patient recovery?
Say that again, Ma. Your voice is not that higher.
Sir, am I audible?
You are.
Sir, my question is, beyond the surgery itself, why is orthopedic nursing care vital for patient recovery?
Like, as you know, each department and each specialty has its own type of treatment. Can you hear me?
Yes, sir.
Yes, sir, Vamshi is there with you? Yeah, I think, yeah. Yes, we can proceed further, sir. You're not audible, sir. You're not. Please unmute yourself, sir. Please unmute
Echoing
yourself.
actually.
Yes.
Can
Yeah.
you see here now?
Now,
Yes,
now
sir.
you're okay, sir. Yeah.
Okay. So each specialty has its own way of treating the patients and the protocols.
Yes.
Yes.
Now, orthopedics is particularly important because each joint is its own way of functioning, and we need to know what we have to do. So, what is acceptable and what is unacceptable.
Yes.
So, that is why we have to be careful when doing with the orthopedic patients.
Yes.
Yes, sir. Thank you for your valuable insights. So now we are going for the main key aspects of orthopedic fundamentals in nursing care. We are going to the core points, immobilization and pain management to ensure the proper use of casts, links, and braces while assessing and managing pain effectively for the patient comfort and healing. Early ambulation to reduce other kind of pneumonia, DVT prophylaxis and all. Positioning to prevent and correct the body alignment and the use of pillows and traction setups to prevent deformities for the patient. DVT prophylaxis to avoid that further complication for the patients, handling traction and drains to avoid other complication to give a sign to the surgeons for a early recovery and early treatment for the patient, surgical site care while doing aseptic procedures and taking care of the patient, assessing the temperature and all to give the signs of infection, and we can treat the patient as soon as possible. Preventing infection, the following doctor's orders and the patient attenders education to reduce the misconception from the attenders after surgery. In the home also, we can mainly help the education from the attenders to help the faster recovery. We can go for next slides.
So I think this was this only are the parameters which we will be discussing further. So we are just going to just keep our session time bound, and we do have one more speaker, Rachel. Yes, sir. Rachel, you wish to take over.
Yes. Immobilization. Soon after the patient has met with the RTA or any of the polytrauma, first is immobilizing the patient. While transporting and all, it is very important. And also, after immobilization, once the patient reaches to the hospital, then we have to avoid further worsening. and then elevation of the legs, like with 1 or 2 pillows, and to provide some swelling pain, because it will lead to the swelling. As immobilization is important, the same way elevation of the limb also plays a vital role to provide support, and also reduce the, as a nurse we have to take important part in avoiding pressure sores and all. Sir, is there anything else that you would like to add to?
Yeah, sure, Rachel. Like you rightly said, elevation is utmost important. The most important thing we need to remember is it's not 1 or 2 pillows. Always you should have the limb elevated above your heart level.
Okay.
So let's suppose your patient is lying down, and if it's a heavier patient, you might have to sometimes use 3 pillows.
Yes.
And if
Yes,
the
sir.
patient is sitting up on the bench in front of him, we should have at least 2 or 3 pillows. So whatever we do, the affected part should be above heart level so that the gravity will drain the swelling down.
Okay.
So this is what I want all of your nurses to remember, because usually we give us very small pillow and we think we have elevated, but it's not doing its job. Okay, so always
Yes.
elevation should be above heart level.
Yes.
Okay, sir.
And
Thank you, sir.
Thanks for
And
Rachel.
sir,
Thank you.
1 second, one thing I wanted to ask. I think this acronym is a very fitting parameter for everybody for ortho-related injuries. RISE, we call it as
Right.
a RISE. I think yes, this is also
True,
important.
ma'am.
Yes, and regarding compression, like when are we supposed to provide hot compression,
Your
and
voice
when
is
are we
gone.
supposed to?
Sorry, 1 second, madam. What did you say regarding?
When are we supposed to provide hot and cold compression? Like
That's
immediately
a very
soon
good
after
question.
surgery. Yes.
Thank you very much for the question, because I have seen recently one doctor after the injury had a hot compression. So the
Yes.
most important thing is any acute injury, it should be ice packs, because they decrease the vascularity, thereby decrease the diffusion of your fluids and the swelling. So usually the ice packs, what it causes is vasoconstriction,
Yes.
thereby decrease the swelling. So number one, any acute injury is ice pack. Number two is you should not leave it for more than 5 minutes on that area. Otherwise,
On the
you'll get
particular,
what's like
yes.
frostbite.
Frostbite,
So you can
yes.
repeat this every half an hour.
Yes.
So what I suggest the patients to buy is this silicone gel.
Yes.
They can put it in the refrigerator, in the freezer. Every half an hour, they take it out, put it for 5 minutes, and then reposition back in the freezer. And later they can use it for hot fermentation also later in the life.
Yes.
So acute injuries, ice pack. Chronic pains like back pain, neck pain, and all, there we use hot packs.
Not compressions, yeah.
Yes.
Yeah, very valid point, sir, because sometimes we see only, this is regarding, I mean, no knowledge is been seen among the treating nurses sometimes, as you said, acute versus chronic injury. Yes. Further, we do have a nurse from recovery who is Monica. Yes, Monica, over to you.
So first I will thanks to Yashoda Hospital and Shanti ma'am for this opportunity. I'm Monica working in Yashoda Hospital, Somajigod as a staff nurse in post-operative area. Compartment syndrome, where very less we are seeing, most probably we are seeing post-operative. So mostly here we are identifying undue pain and in diffuse swelling of distal extremity, color change, bluish discoloration. If
If these signs are present, she meant to ask whether should we escalate to the duty doctor and keep observing for all this, signs. Like sometimes we always see ortho doctors, they say just move your fingers, move your toe fingers, all that. Yes, sir. Over to you regarding
Yeah.
this
Thank you.
neurovascular.
And nice one, Monica. So the first and foremost is compartment syndrome. It is vital because you should act in time.
Yes.
If you don't, the area will go into avascularity, and thereby the tissues die. Once it's there, the tissues die, it's irreversible. So we have a brief period, like, at the most 6 hours for the tissue to receive enough vascularity and also oxygen demand. So that is why we have to identify the compartment syndrome immediately so that it can be escalated for decompression of that area.
Okay, okay.
And how do we identify, like you rightly said, first is undue pain.
Yes.
See, when you ask the patient to move the toe, where there's a fracture in the thigh, normally they should not have pain. But if they are shouting in pain, that means there is something in the leg that is tight. And also significant swelling. You're trying to hold that leg and or the thigh, you feel it's like rock solid. That means there's a lot of fluid and blood that is gone into the compartments. And the coloration, you said blue is discoloration. This is because the vascularity is decreased. The venous return is decreased. That is why instead of being pink, it's going into blue.
Blue.
And also the other important feature you should feel is pulses.
Yes.
Peripheral pulses, you should, if it is foot, you should feel the dorsalis pedis and also posterior tibial pulses. If it is upper limb, you should feel for the radial pulse and also ulnar pulse.
Yes.
And usually ask the patient to move the fingers or the toes. If the patient is shouting in pain, that means there is something you have to worry about and immediately escalate it to your next senior, like it can be a senior nurse or a duty medical officer.
Yes. Yeah. I think apart
Yes.
from giving medications and painkiller, this is very important, vital parameters which sir has rightly said just now. Yes, going forward, as we were discussing about this compartment syndrome. Yes, and yes, over to you, Rachel.
After the surgery, we received the patients with so many drains and tractions connected to the patient. So usually during the transport and all, they may get misplaced. So as a nurse, after receiving the patient from OT to your ward, it is very important to see whether all those drains and tractions are in place. And also you should know that you should take care, see that the traction band is loose or tight, and it should not be too loose or too tight. Then the drain, whether they are clamped or unclamped, also the nurse should see. Sir, is there anything like particular uh, placement for the tractions to be kept? Usually they say that it should not touch the ground and it should not be too tight and too loose. Is there anything in specific so that we can take care in further, sir?
Few questions.
Now,
Yes.
so there are two things. One is pre-operative and other is post-operative. Pre-operative, let's say, suppose there's a hip fracture. We usually put traction so the patient is comfortable, so that the bones doesn't move and cause pain till the patient is getting operated. Post-operatively, we put some tractions to maintain that. Usually we put splints. If we operate on a leg, we put long knee brace, or if it is upper limb, we put abduction braces and all. So what I usually tell all the nurses is, if you have any doubt, please call up the primary consultant or the team to find out.
Yes.
Now, I'll give you a nice example. Recently, an experience for me here in the hospital. I've done a nice shoulder surgery, rotator cuff repair, gave a special splint called abduction splint where the arm should be up there.
Yes.
Now, one of the nurses has taken it off, left it down, took an X-ray. When I asked her why did she do that, she said nothing is written there saying not to take the splint out. It's so surprising. See, you have done a mistake already.
Yeah.
Usually it is better that you tell your consultant, see, things do happen, mistakes do happen,
Yes.
but you should not try to cover up.
She could have
See,
checked by asking.
exactly. See, why will
Yes.
I write it? Don't take out the splint, don't take out the IV line and all. If it's something is there, that means it should be there.
Yes. Yes.
If you have doubt, we are only one phone call away.
Yes.
All I could have said is, yes, don't take it out or something. So these are some areas because see, I spent 3 hours in operating on this lady.
Yes.
Patient has spent 3 lakh rupees. One small mistake of taking it off, everything is ripped off.
Okay.
So what should we do again? So these are the things we should be cautious. Like you rightly said, Rachel, splinting and traction should not be too tight. Make sure the peripheral movements are there, like fingers or toes.
Yes.
Again, like Monica said, compartment syndrome is not there because
Yes.
very tight bandage also can cause like a compartment syndrome. The
Yes.
easier way to see is distal pulses. And
Yes.
also you can ask the patient to see if they can feel and move. Unless there is a block. If you give the block, then the patient won't have movements. Okay, so these are the areas we should
Okay.
concentrate on.
Okay.
And
Thank you.
And as we want to, just share this insight with all our viewers that, orthopedic post-operative care is very, very important, as sir has rightly, narrated about one incident, which is a little fatal, more fatal in nature. So I urge all the viewers to just keenly observe and your patients and do ask your doubts when you're not sure about any order which is maybe prescribed or may not be prescribed. Yes. Over to you further, Aparna. Yes.
Yes, sir. After orthopedic surgery, especially with procedures like bilateral take care, the first 24 to 48 hours are critical. So, vigilant nursing observation can prevent complication and save lives. Like pain assessment, patient response, regularly assessing the pain levels, and we can check the response to analgesia. Vitals monitoring, as you discussed before, like respiratory rate, heart rate, saturations, and Glasgow coma scale as well, and motor and sensory assessment like checking of numbness, heaviness, weakness on lower limbs. And this is especially important for post-epidural or bilateral trigger patient to catch the nerve issues, sir. And high-risk medication safety is more important in this time. Medication like epidural infusions, bupivacaine, and that will be handled with extreme care, sir. So I would like ask you, sir, the in bilateral TKR or major ortho cases with epidural infusions like bupivacaine, what is the single most important early sign you want nurses to report immediately that tells you can complication is developing?
Yeah. See, now after your epidural, you
Yes.
would expect whichever drug it is, ropivacaine or bupivacaine, that area will have decreased sensation, mainly the pain sensation.
Yes.
But if the patient is unable to move the toes completely, even after the spinal effect is gone, see, usually spinal anesthesia causes almost like a paralysis like thing, wherein there won't be any movements. But epidural,
Yes.
what we do is we titrate it. We give very low dose of one of these anesthesias. So that will block the pain fibers. So patient won't complain of pain, but there is no motor block. So if the patient, even after spinal anesthesia is gone, still not able to move the toes or the hand, that tells us there is a problem probably in the nerve. See, sometimes when some doctors we have seen doing hip replacements and later the foot doesn't move. That's called foot drop.
Good job.
Probably when he
Yes.
was doing, he has cut off the nerve. That's number one. Number two is like, the leg is out. See, while shifting, sometimes again, this happened to me. One of my patients being shifted out, the trolley boys has held the leg, the other boy was holding the body. Somehow they managed to dislocate the hip joint. So when I went back to see the patient, I could see the foot is out.
Okay.
But the patient didn't complain of pain because patient is on epidural anesthesia.
Yes.
So these are things. So abnormal position of the limb, or if you have abnormal movement, that is patient, there is no movement at all. So you need to please escalate it so that we can look into what is happening.
Okay, sir. Thank you for your valuable insight, sir.
And very careful transportation of these surgical patient is very important. You know,
Absolutely. I
some
make
yeah.
sure actually one of my colleagues, junior colleagues is there when shifting the patient also, especially hip replacement. But for my bad luck that day, it became late and he went off for lunch.
So these are all adverse errors which we are just experiencing through this learning. Yes, and yeah,
But luckily, this
and
patient did well. All we
did
had to
well.
do is pull it back into patient, and patient is walking happily. The only reason I'm bringing up these examples, sir, these can happen to anybody.
Yes,
So,
yes,
so you have to make sure that we concentrate on even the minutest things.
yes. So, a
Yes.
very key important role of early ambulation and mobilization is very important, I think, for all ortho-related and bone-related surgeries. Yes, now we have Rachel, who can just ask, and then we are just nearing to the end of the discussion. Yes.
Yes. As told earlier, as immobilization, like soon after the injury, as immobilization is how the immobilization plays important. The same way after the surgery, early mobilization also enhances the faster recovery of the patient. So, along with the physiotherapist help, it is important to get the physiotherapy and exercises done as advised by the doctor, and no extra weight to be kept on the operated limb, then early embolization and within 28 to 48 hours according to the protocol of the surgeon and according to the orders. So, sir, what would be the perfect time for the patient to be mobilized after the surgery? Is there anything in specific?
Yeah. Now, the most important thing is the type of surgery. We try to mobilize and put weight as much as possible because number one is to get patients' confidence. Because a lot of patients come to us thinking that they have to take bed rest for almost a month or two. Somebody has to put a bedpan, they can't go to the washroom, these sort of things. But most of
Yes.
my knee replacements, as you have seen, Rachel, in our hospital, we mobilize within 3 hours. We make them walk in the recovery itself. So
Within
by
three
that,
hours,
patient
yes.
gets a lot of confidence. They come prepared that no, you have to be on the bed for almost a week, and they're walking here within 3 hours. So they're so
Yes.
happy and they participate for the next 3 days easily. So their mobilization is better. Now there are some surgeries like hip replacement. What we do is initial phase, like you have put partial weight bearing. So we allow them to walk with the walker. So the principle or the goal is to mobilize at the earliest and give as much movement to the knee as possible. Because after my ligament surgeries, I allow them to bend only up to 90 degrees, not 100, because that will come off. So what I request all my colleagues like you are, please look at the post-op orders. If there is any
Yes.
doubt or if it is forgotten sometimes, like no any human can do, please call up the doctor saying what are the instructions for mobilization. So that will
Yes.
go a long way. Not only immediate post-op, even when the patient goes home, we usually give a clear order as to how they should be mobilized for the next 6 months or 1 year.
Yes.
Yes.
So yes, I think that was very great, validated points you have discussed. I think small, little, display in a form of templates would definitely help all the bedside nurses because, yeah, these are the instructions they may, likely to forget. And why should we put the patient at risk? Yes. Yes, and that was very, nice points, sir, you have said, clearing a lot of myth versus, lot of wrong practices. Yes, we are just going to end the session, and I urge all the viewers to refer www.yashodahospital.com for more updates, academics, and also watch patient testimonials and learn from our, clinicians for evidence-based learning. So, thank you, sir, for your valuable time. I thank all the speakers. And due to technical issue, we couldn't feed more. But then, yes, we will like to have these kind of webinars in a series wise. Especially, I'm just thinking care of skin tractions and skeletal tractions. The next, maybe after few gaps, we will also learn from you, sir. Yeah, thank you. We end the
Yes.
session.
We'll do that next time. Thank you. Thanks
Yes,
for inviting me.
Thank you, sir.
thank you,
Thank
sir.
you.
Thank you, sir.